Um, hello, everybody. My name is Ziv Haskal. I'm the Vice Chair of Career Development at University of Virginia and an interventional radiologist. Welcome to the latest installment in our evening keynote lecture series. A quick reminder, you can find all these on our faculty development webpage. We'll make the link available. Tonight, we have a unique and exciting program. We have the renowned, charismatic, eclectic, and erudite Bob Vogelzang, professor, interventional radiologist at Northwestern University in Chicago, with a tremendous several decade experience in medical malpractice work, all sides, all aspects, has run and still runs conferences on it, and a great panelist, Bruce Geely, who is an attorney and the chief operating officer of the Piedmont Liability Trust at the University of Virginia. Professor Mary Lee Jensen, Emeritus Professor, Interventional Radiologist, Interventional Neuroradiologist, UVA, and Professor Tom Sauce from Cornell University. You all know him, you all love him. And we hope this is an exciting presentation for you. Bob, all yours.
Thank you, Ziv.
Let's click that button off.
Are we good? Can you see it?
Yes.
Good. Welcome, everyone. This talk was formulated based on my experience, and I became aware after a long time of working in the medical legal field as an expert, something I got started with maybe 20, 25 years ago, that many of us physicians were poorly informed or misinformed about the process, which of course affects us all. It's the system under which we work. It's the system which the United States has chosen to deal with risk and injured patients, and it's a fascinating one. So we'll use my experiences being asked to see cases, to review cases, and to serve as an expert as a launching point for a discussion of some important concepts in medical legal circles. There we go. Okay. So our first case, and there will be a series of
Bob,
cases.
if you can just share your slides now.
Yeah, I can't see the screen.
Oh, thank you. Hold on. I thought I had a second. We had shared it before. I apologize.
As we say, we'll fix this in post.
We will. Share screen. Here we go. Okay. All right. There.
I don't see it.
Share. No, it's coming. There we go.
Okay.
Can you see it now?
Yep. Launch your presentation.
Okay, I launched my presentation. So I gave my introduction. This is our beautiful city of Chicago, taken from the lake. So we will serve up a number of cases, and we have an esteemed panel to give us some thoughts and discussion, and hopefully some of you will have similar thoughts as well. So the first case is a 34-year-old woman with no history of malignancy and a CT scan shown here demonstrating an anterior mediastinal mass, and a biopsy was requested to rule out malignancy. Now remember that I've been asked to serve as an expert witness for the defense, so clearly we know a complication has occurred, as in all of these cases. So the biopsy was performed under CT. Of course, informed consent appropriately was obtained with all the necessary complications mentioned. And it was conducted, a large patient, an obese patient, and the scan and biopsy was done. A transsternal biopsy was elected. And I think we can all see that there was perforation of the ascending aorta. There was rapid decompensation due to mediastinal hemorrhage. Thoracotomy was performed for pericardial tamponade, and the patient ultimately expired. So I was asked to review the case, and the way this format is going to work, I'll go over some of these cases, and we can interrupt with the experts, or we can wait until we see what I did, and that's what happened. So next case, and I'm going to show you two cases here, and then we'll talk about them. 85-year-old man with cirrhosis in this 5-centimeter lesion, which was biopsied to be shown as hepatocellular carcinoma. There are a number of treatment options discussed, and at this time, percutaneous ethanol injection was selected. Many of you may not be familiar with it, but this went through a period of widespread use, formulated by the Italians, and it was effective in treating HCCs. Percutaneous ethanol injection was selected. So the case was performed as you would expect under general anesthesia. The calculated volume of the lesion was 100 cc's, and that's important in this case. CT was used as guidance, and a special multi-side hole infusion needle was made. And I'll show you a sequence of images as the case is conducted. At 25 cc's of ethanol, the following image was obtained. Notice that the alcohol is black. This is at 80 cc's of ethanol. And I don't know if anybody sees anything, but I'll point out some dark black material in vascular structures in the liver. Finally, at 113 cc's of ethanol, the image was obtained and the procedure was terminated. After the procedure, the patient could not be extubated, remained on ventilation, and rapidly became comatose with deterioration, fulminant liver failure, and death in the ICU within 2 days. So, the question is, for the panel, was there a violation of the standard of care in either case, and would you have taken the case? Tom, would you have taken the first case? As a defense expert.
It's a tough case to defend. I mean, it was done under CT. Assuming that the person doing the biopsy knew what the various structures on the CT were, sticking a large needle like that into the aorta would be pretty difficult to defend, I think.
Okay. So you used your definition of standard of care, correct?
Yes.
Okay. Dr. Jensen. No, let's ask Ziv, because he does these, he's a little more familiar with perhaps liver-related material. Would you take the second case? Remember, you're criticizing the doctors who performed the procedure, so you're serving as an expert for the plaintiff.
So a couple of things. Obviously, when considering this case, we get far more information than this and full sets of images. So we'll make some assumptions, and we have to have been practicing this form of medicine at the time that this took place, which means we have to put ourselves into the time probably 15 or 20 years ago or so when this was considered a first-line treatment around the world, and not
Correct.
through the lens of now. So it's an acceptable form of treatment, but the question is, can you defend the amount of alcohol that was injected into that and the calculations there, and the fact that they had some telltale signs going on along the way that should have said red light, green light.
All right. Remember, you're being asked to criticize the doctor. You're a plaintiff expert.
Will I accept that case as a plaintiff expert in support of the patient's family?
Correct.
And the answer is yes, I would.
All right. And Tom, would you accept the case, the number one, the mediastinal biopsy, defending the physician?
No.
All right.
No,
Well,
can I ask a question?
So,
Yes, please. Go ahead.
Just very quickly about Ziv's, the second case. I have never done one of those. I have no idea, but
That
Is
makes
there-
that means you're an expert.
okay, yeah. But is there an accepted ratio of the calculated volume of the tumor versus the amount of alcohol that you're injecting?
We will get to that. I have an
Oh,
answer
okay.
for you, Tom.
Okay,
Okay,
Lee,
so-
you had a question or thought?
I have a comment. So standard of care, I look at it as what would a reasonable physician do in the same situation, who's familiar with those procedures.
All right.
I'm not familiar with those procedures, but I can liken them to some procedures that I do. So the first case I would not have taken for the defense. And the reason why is because this is a situation where I think you could easily have measured the depth of where it is that you're supposed to place that needle. And that needle clearly ended up twice as far away from the skin surface as where the lesion was that you were biopsying. The second case I would absolutely take for the plaintiff. And the reason there, I kind of liken that to a vertebroplasty. So you've got your needle in the area where it needs to be. You're putting in some embolic material, take an image to see where it is. And the moment that I had seen on that second study that there were those dots of darkness, which I saw in the vessels, I would be saying, this material is not going where I want it to go. And as I recall, in terms of the volume, the next time they took a look, they went from like 30 or 40 cc's to 110 cc's.
80,
So you're all,
from 25 to 80.
Okay, so I mean, you're already looking at, 2.5 times the volume, and you already know from that one image that there's material in a vessel that's not supposed to be there. So
All right,
those are my thoughts.
So our three experts all said something that's very relevant and that I want the audience to pay attention to. What is the standard of care? Well, the standard of care is not what you and I think it is when we're talking about how something should be done. Rather, it's a specific legal definition. This is the Illinois pattern jury instruction defining professional negligence. And it says the failure to do something that, in our terms, reasonably careful interventional radiologists would do, or the doing of something that that individual would not do under circumstances similar to those shown, is professional negligence. It goes on to say, deviation from the standard of care means the same thing as professional negligence. And the law does not say specifically that. So this again is an expert's call. And finally, the important thing, you must rely upon opinion testimony from qualified witnesses, which means experts. So with that in mind, we have a different set of definitions, and one which I would tell the audience to pay attention to because it is very, very relevant in this matter. Standard of care is not what you and I talk about sitting around when we're saying how I would do the case. It represents a different legal standard. Bruce, can you comment?
Yeah, I mean those are great points. What I often tell if I'm giving just like an introductory malpractice lecture to residents or medical students is that standard of care is not something that is in any particular textbook. It's not what any particular doctor says. It's not like if it's an OB case, you can go to Williams and obstetrics and it may say standard of care in there, but a jury doesn't have to buy it. That like you said, that is, and I think that's surprising to a lot of them, that standard of care is not something, there's no law that says what standard of care is, there's no regulation somewhere. And in any particular case, 99 radiologists may say something is the standard of care. One of the radiologists may disagree. And if that one happens to be an expert in the case, the jury gets to hear both. They can judge the weight of it, but they get to make that ultimate decision. And I think that's always very sort of surprising to students and residents learning about this system.
It is indeed.
Can I bring up a point there about standard of care? I think one of the things that you have to be concerned about is there are certain procedures and things that at least we do now that definitely have national guidelines. And so I bring this up because a lot of the cases I see are stroke cases.
I see.
And there are very well defined how you're supposed to treat a stroke patient in terms of, timing of giving drugs, for example, TPA. You give it outside of the 3-hour time window. In certain patients, you have now gone outside of the guidelines, and it is easy for a plaintiff's attorney to say that it's outside of the standard of care. So
Right.
In your field, you need to know those
You do.
things.
But we all know that the societies are very careful to indicate in their verbiage that guidelines are not standard of care, which again is a legal profession, legal definition. So in case one, case two, I agreed to serve in both cases. Now let's examine my rationale. In case one, I did not find any violations of the standard of care despite the abysmal outcome. My checklist, which we'll go over, showed to me that it was an indicated procedure. Despite what Dr. Sass said, I thought it was properly performed. It was an obese patient, difficult needle placement. It was a known risk, and the response was appropriate. That is to say, they immediately called the code. But, and here's the big thing. Would I have done the case that way? Absolutely not. No way. I wouldn't teach my residents necessarily to do it that way, but I wouldn't object to it. Let's remember, it's a very likely benign lesion with a young patient. Could have been done via mediastinoscopy, and it was a difficult small lesion. So Tom, further to your comments, it was a difficult call for me. It was not exactly brilliantly performed, but that speaks to the issue of what the standard of care is. It's typical care. It's not brilliant care. Okay.
And Bob, speak to that point when you're asked as a medical expert, can you say with a greater than 50% degree of medical certainty that you finish that sentence?
I think that's an excellent point, Ziv, and that often is the criteria. That is to say, if more likely than not, an average or typical physician would have done it in the same or similar fashion, it meets the standard of care. But ultimately, Ziv, you and I and all of us know that it's the call of the expert, and there are no criteria or standards. I know Lee mentioned about some things, but for the most, there are none.
Bob, would you comment on the size, the diameter of the gauge of the needle that was used? Never mind the fact that it was not measured in length, distance.
Well, clearly problematic, Tom, but an 18 gauge, it was a coaxial, I believe it was an 18 gauge needle, right? If I recall,
It looked big.
Yes, it was big, bigger than many of us would have used.
And it also looked like, sorry, it also looked like, at least in the imaging that you showed, at one point it was, barely in the it was just in the subcutaneous tissue, and then all of a sudden, the next thing you know, it's intrathoracic.
Bob, I'm going to suggest we move to the next case. I know you've got.
All right. So how about case 2? Would you criticize the interventional radiologist who did the case? Of course I did. And there are some obvious reasons. Some cases are straightforward. This one for me was, Dr. Jensen elaborated very nicely why. Was it applicable? Yeah, lots of literature on ethanol. People still use it now, but lots of literature. Was the guidance and monitoring appropriate? General anesthesia is fine. Ultrasound or CT meet the standard of care. So where's the violation? Well, bottom line is, first and foremost, the ethanol dose was too high. The absolute maximum dose for any patient under any circumstances in this is 1 milligram per kilogram, which in this gentleman was about 60 cc's. That's if you were injecting it sequentially intra-arterial or intravascularly. But nevertheless, it far exceeded that. Secondly, and extremely importantly, there was non-target embolization of the ethanol into hepatic vessels. They should have stopped much earlier. And the cause of death was therefore hepatic necrosis in a cirrhotic and ethanol poisoning. So what is the standard of care? Basically, it's reasonable carefulness, whatever that means. And it's defined fairly vaguely because it ultimately is, as best I try to tell people, average care. And most importantly, standard of care is not determined by books, not determined by literature, but it's determined by the opinion and testimony of experts in our system, as Bruce well knows, some of whom really aren't, but they will say so. And it's given by a human being, telling a jury, who are also human beings, what reasonable carefulness is. So for me, my checklist is as follows when I look at these cases, and I'm sure some of our other panelists think the same way as well. Was the procedure indicated? Was it performed properly? Was it a known possible outcome? Was it recognized in a timely fashion? And was the response appropriate? So all of those come into play, and at each level, we have all seen examples where one of these violated the standard of care. And that's the checklist that I made. So let's move on. Would you take this case? This is a 25-year-old with long-standing cystic fibrosis and hemoptysis with massive bilateral bronchial arteries, bleeding, obviously. And the patient was embolized in the following fashion. That bronchial artery, and you can see it going out and filling pulmonary arteries here. And it was embolized with the following material. Patient died of hypoxia due to massive shunting to the PA. All right. So that's case one. I was asked to defend it, I believe. Yeah, I think I was asked. Yeah, defense case. Okay, case four, second case in this series. Pre-op filter for removal at 2 or 3 months. Typical, nothing unusual. First attempt tilted, failed. Second attempt forceps. There's the filter, the stabilizing struts or secondary struts have been a little bit deformed. A loop snare technique was used, again, could not extract it, and they decided to work with forceps.
And that is the filter saying, you can't make me come out, I'm not coming out, as it is scraping the length of the vena cava with small, sharp hooks.
Right, it's basically an octopus. It's a razor. And this patient died immediately. So again, there's my standard of care checklist. Tom, would you defend the first case?
You know what? I was so fascinated by the second case, like Biden, I've forgotten what the first case was.
You can use it. You can pass, Tom. It's okay.
No, seriously, just.
Bob,
Remember, yes.
If I were approached by the first case, I could see myself in both roles, as difficult as it is. And while I recognize that an egregious error was made, I could see serving in both roles in that first case.
That's an outstanding point, Ziv. All of us have been there, have we not? Which is, you know, I could take either side in this. And remember that we're not working for the plaintiff or defense. We're really working for the court. I think that's an important element to measure. We are serving the system, which has chosen to use this method in America. You can quibble about the method, you can quibble about the system, but that is the system. We're serving the justice system. And so Ziv makes a good point. And sometimes that's a way to analyze the case. Is it not, Ziv?
And I would further emphasize that as for those in the audience who have served as experts or been subject to suit or are considering doing this, that you have to be prepared to work for plaintiff cases as well, because you have to have a fundamental belief that the tort system is there for a reason.
So can I bring up a point about the first case?
To be compensated.
Yes, Lee.
Okay, so the first case, again, I don't do this, but I do embolize fistulas in the brain. And it seemed to me that it was an exceedingly large amount of particles that were first put in, the smallest particles, 4 vials. That just seems a lot to me. And since you didn't show me the whole run, I don't know if I can actually see the shunting, but I know in tumors that shunt, if I put in just a little bit of small particles and I don't see any change, I'm going to immediately go to the bigger ones and the bigger ones and the bigger ones.
So for those of you who don't know the specifics of this kind of case or out of specialty, what Dr. Jensen is saying basically that if you are filling a bucket and you keep pouring into it and you're not sure why it hasn't filled to the top, at some point the light bulb has to go off and say, I wonder if there's a leak at the bottom.
Yeah.
That's what occurred here.
So
I just want to make one quick point going back to Ziv's point about the plaintiffs and defense. Yeah. Just say as a lawyer, I've done plaintiff and defense, but mostly defense in my life. But an expert that I hate to get defending a case is somebody who comes in and tells me, "Oh, you're going to win this case. I only do defense cases, and you know this is this is a clearly defensible case, and I know that because I only defend doctors. Those folks get cross-examined to death. They have no credibility, and it is absolutely true that if you are willing to take both cases, I mean, you still need to give honest opinions, but if you're willing to take both, that will really enhance your credibility and also make you more attractive to lawyers if this is the kind of work that you want to do. That's a great point.
Excellent point, Bruce. A terrific point. I agree 100% that advice was given to me years ago. Said, you know, Bob, you have to take both cases. If you're going to do this work, you really have to look at them both, because ultimately, as I said, you're serving the justice system, the tort system that we've used in this country.
So I've
ahead.
taken both. Obviously, I really have taken both defense and plaintiff. On the other hand, I disagree a little bit in the analysis of how one approaches, because maybe there are elements of defensible versus non in that case, even though I couldn't remember at first what the hell the case was. But
yeah, it's just bleeding, bronchial bleeding.
At some point, you really do have to make up your mind, because the one thing that I don't do is get involved in a case where I need to be talked into or allow myself to take a case where I don't really fully, or I'm unable to make up my mind whether it was appropriately handled or not, whatever appropriately means. So yes, in terms of our analysis, maybe there are elements of that case which might be defensible, but there has to be, in your own mind, a clear indication. Or if I can't make up my mind, I will not take the case. In other words, if I see so many elements that are either both defensible or not, then I might not take that case.
Excellent point, Tom. I agree 100%, and we've all learned the hard way. So what about the filter case, Ziv? Yes, no? Remember, I'm asked to criticize the physician.
Would I be comfortable being the plaintiff's expert in that case? And the answer is yes.
Okay.
We also have a couple of questions from the panel that might be interesting. Let me throw them out, which is, if you can see yourself arguing both sides, is that a sign that you should do neither? You know, and thus, should you look at these cases blindly at initial review? The second one is easy. They don't come to you as if you can choose which side. They come to you as, here's what I need you for. But the question is if you're on the fence, which builds on what Tom had said, then should you not step in? Or how much surety do you need to be able to serve suitably in the role?
So can I answer one of those questions? Actually, I thought Marcus Hook's question was appropriate, because there are times we will get contacted by a lawyer about a legal case. And what I will say is, I don't want to know who you are, if you're for defense or expert or for plaintiff. I just want you to send me the films and what the radiologist knew, and that's it. So I want to know what the indication was, and then I'll take a look at it. And you can do that. The problem is that, and I asked them to send the radiology report in a sealed envelope, and I open that when I'm done with whatever my review is. Now, the problem is the fact that a lawyer is sending it to you, you know there's an issue, but you can actually separate yourself from.
It's really interesting, Lee. In 28 years, I've never had that opportunity.
Oh, I have.
So,
yeah, I have.
Sorry.
Yeah. Well, it does point out, I think, an important thing, which is try to be as objective as you can. And I'm sure Bruce would agree. He wants, above all, an expert who's comfortable and has made an assessment in as objective a fashion as possible.
Correct. We want to know those problems that if we're defending a case and you see problems with it, or like what Bob said, going back to that first case where he said that he would, if he were asked, would he do it this way himself, and he would say no. I want to know that before Bob gets deposed, and gets asked those questions. But yeah, absolutely honest. I wrote down a few things before coming on to be sure to make sure to say, but being honest with the attorneys that represent you is critical, both for you and the case. So absolutely, number one, most important thing.
Good.
So a plaintiff's attorney may spend perhaps how much in moving, deep into a case of their own money? You want to share some numbers so people get some sense?
I mean, it's not unusual for a case all the way through trial for a plaintiff's lawyer to spend, depending on where you are, of course, in Virginia, $150,000 to take the case up to trial, probably $100,000. If it has a couple of esteemed people on their panel like you folks, probably gets up to that amount. But yeah, they're looking at a significant chunk of money, and if the plaintiffs lose, the lawyer and their firm have to eat that cost. So they don't, they want to be sure of their case before they take it forward.
Can't be wishy-washy in this role.
And I would point out from personal experience with friends and other people I've met that this is not what many people think, which is a lotto ticket. If you treat it as a lotto ticket as a plaintiff's attorney, you'll be rapidly out of business. So
I can tell you that before when I'm called about a case, the first thing I tell the attorney is I'm happy to look at the case, but I am not for hire. And so I will tell you exactly what I think. And it may well be that I can't do it. And I will even tell you why.
correct.
And
Absolutely.
And so I think in essence, my job is, and I tell them, my job is not to be your whore and to tell you what you want to hear, because that doesn't serve you right anyway. And I tell them that specifically. If I tell you what you want to hear, and then you are up against an expert on the other side who is going to skewer you and me, that is not what you need or want. You want to stop this case if it's not worth pursuing, one way or the other,
Excellent. Yeah,
as
good
soon as
point.
possible.
All right,
Well,
let's move on. I took both cases. No, excuse me. In case 4, and we'll address it a bit. I refused. I said, no, it's indefensible, the bronchial artery embolization. I thought it was overwhelmingly too much material. There was clear shunting, a clear violation of standard of care that I could not defend. In case 2, I think it was obvious. It was just a grotesque failure of that individual not knowing how to remove that filter and rather grabbing it out. Kind of horrific to watch. All right, let's move on. This is a case, a 5th case, a plaintiff case. I was asked by an attorney to look at this case. A woman with an expanding psoas bleed, continued pain and expansion, and as we often are asked, let's do a lumbar artery injection. It was on the left side, and here you see. So a routine catheterization was done. This is one lumbar artery. I don't know. I think it's L4-5 left. Next one up, and I think you can perhaps see, if you can see my cursor, you can see little dots and so on. This was embolized successfully. It's fine. And they went to the L2, I think, level left, still looking for bleeding. And this view was obtained. You see anything, Lee?
Yeah, Demkowitz, or as a spinal artery. It's a
What?
cone. It looks like the conal basket there.
We don't know that.
Can you point to that for people, Bob?
There.
Thank you.
Yep.
That vertical structure that looks
This
like
vertical
like
structure.
Old Faithful there. That's an artery that is characteristic for going to the spine.
A
So-
dagger in the heart of the case.
Yeah. And so embolization was performed. Thank you, Lee, for the.
Sorry.
No, the peek and shriek response is an important element. If you do that, and I call it a peek and shriek, you have to think long and hard, depending on who you're reviewing for. And this, of course, was after embolization of 300 to 500 micron particles.
Yikes.
Yeah.
So what was it that they saw? They thought they were embolizing at that level.
Well, I think after the fact, I don't think they saw it initially. Perhaps they did. They said, well, we moved the catheter past it, and I felt comfortable embolizing from there, but clearly.
No.
All right. So I took this case. I don't think we need to discuss it any further because this is a bald-faced violation of standard of care. So the scorecard. As I said, I declined to serve as an expert in the first bronchial artery embolization with death. I did serve as an expert for plaintiff in the IVC filter removal. And in the lumbar artery embolization, it was an easy call. Now, not all calls are easy, but this one was. So, any comments thus far about standard of care, panelists? If not, we're going to move on to the fun part of the lecture.
I wanted to take a moment and perhaps we should chat with the audience who are
Oh
considering
yeah, let's do that.
how some of this process occurs, where you review a case, you have conversations, you may or may not need to develop reports, and ultimately these things may move to depositions. And how would you describe what a deposition is like for those who haven't been in that situation?
It is a formal adversarial process designed to explore the expert's opinions and the bases thereof. But as we all know, and this is where doctors don't really understand the law is a formal adversarial process designed to elicit the truth and to arrive at a conclusion which produces justice for those who are sued or being sued or under prosecution. And to that end, we don't really understand how lawyers can go at it hammer and tong and be very aggressive and then go out and have a drink. But there it is, because it's a formal and adversarial process designed to elicit the truth.
So my version as being on the other end is that somewhere around hour 3.5 come the really difficult questions.
Yes.
And you're expected
Correct.
to be tired and weak. I see Bruce smiling.
Yeah.
Is that strategic? Is that something taught in
It-
first or second year of school?
It depends. No, you don't get taught any of that in law school, and it really, it's experience. I mean, it depends on the experience of the lawyer sizing you up as an expert. Very young lawyers typically follow a pattern. They start with your qualifications and go through to the case. And very experienced lawyers may come right out of the gate and ask you some difficult questions up front and save all that stuff for the end. A lot of lawyers, if they're taking an expert and they know it's a real strong expert, will just look to get the concessions they think they can get at the deposition and don't even bother to have you go in your speech about why the standard of care was violated, because they know what they're going to hear. So it really depends, but definitely fatigue can be a factor, and the dynamic in the room will dictate, dynamic and experience of the lawyer will dictate how that happens.
Yeah,
Correct.
the
I
other thing they try to do too, if you do a lot of this work, is they will get your old depositions and they will read them and they will look to see whether or not you are telling the same story in situations that are like-minded. Because I see that a lot, again, with stroke cases. So you need to make sure that you are consistent with your testimony. And if you do change it, you're changing it because something has changed, perhaps in the way you're now treating the particular issue at hand.
Or there may be a subtle difference in the case that you, if asked,
Correct.
would explain it. One of the things that I think is really important is that you can't say one thing in deposition and then have second thoughts about it and say something different at trial.
Absolutely.
Because that you will get hung up on.
That is so much fun. That is so much fun. Yeah.
Lawyers love it. And I always say, you know what? I agree with myself if asked in the deposition. But you do have to, that's another important point, Tom, that you at trial, your deposition is fair game, and they will often try to impeach you from your deposition. So you need to know what your opinions actually are. So let's move on. Let's get ready to rumble here in the third and fun part of it, in which we review cases that I have opposed, where Dr. Jensen and I have been on opposite sides of the case, and another one where Dr. Sass and I have been on opposite sides of the same issue, pointing out the nature of this and the nature of experts and their legitimate disagreement, even though we're colleagues and respect each other's opinions and skills. So case one is a patient with an empyema. There's the CT scan. This was drained. It was loculated. Needle placed under CT. Some of us might use ultrasound, but it doesn't matter. And a catheter was placed. Looks fairly straightforward. No drainage was occurred overnight, or minimal amounts. And in a routine fashion, as we all would, the patient was brought down for a catheter exchange, which was done under fluoroscopy and in a fairly rapid fashion. The catheter was exchanged for a larger 12 French, and the patient felt a pop in his back upon insertion. Patient then had TPA instilled, no contrast was given, and paraplegia ensued fairly rapidly. What happened? CT was performed. Any thoughts of what might have happened, Dr. Haskal?
Well, it took me 5 minutes to get up off the ground. I saw this case earlier when you kindly shared this before. And it may well have to explain to those non-radiologists. Extraordinary barely encompasses the, how shall we say, the unusual nature of these findings. Please go ahead.
Correct. And so a CT scan shows that the catheter has come to lie in the spinal canal.
Even I can tell that.
There you have it, Tom. Even us non-neuro.
My wife is a neuroradiologist, but even
Bruce
I can
can see
tell
it.
that.
This is actually intended to drain evil humors
Yeah, there you go.
from the mind, or unremitting depression, I suppose.
So, and this case is done to illustrate how this process occurs, because it's an unusual one. Was there a standard of care violation? You know, I was not going to take this case. I was to criticize for a plaintiff. And then I looked at the films and I realized that two views, roughly about 45 degrees apart, had been obtained. And in both views, the catheter overlaid the spine. And I elected to take the case. Now, I criticized on the basis of not confirming or not looking at the films as they were obtained. I testified against it because I said the standard of care would not have been violated if only a single film had been taken or if contrast had been injected. And I thought that the interventional radiologist had an obligation to see that the catheter was misplaced. However, our esteemed panelist, Dr. Jensen, disagreed. And in her written opinion, she said,
That's what I said.
That's what she said. The likelihood of a chest tube inadvertently entering the spinal canal when being placed or upsized by a radiologist is incredibly remote, and the foramen through which the chest tube passed is small and can be difficult to access intentionally under the best of circumstances. She had never seen or heard of this happening. And you know what? Lee and I both agree. So how on earth did we end up on opposing sides of this issue? Lee?
Well, so, and to be perfectly clear about this, I actually had brought one of my TAB colleagues, Juan Lazagasti, into this because I don't put chest tubes in.
But
and it was a little bit more complicated that the first chest tube had been placed by a neuroradiologist who does everything. And then the second one was exchanged by a radiologist who wasn't a neuroradiologist, who she's the one that did the exchange.
correct.
And the patient felt a pop, but at that point in time, one would think a tube that big, even without TPA being placed, would have caused some sort of at least radicular. Because let's face it, how did it get in there? It had to go through the foramen, you know, right next to the nerve root, and she felt a pop, but she didn't have pain immediately, as I recall. So this is incredibly. I mean, it's a terrible, to me, a just awful situation where it's completely and totally unexpected, and the patient's initial neurological or lack thereof wouldn't make one say, oh my God, you know, this thing is in the canal.
Okay, and there you have it. And I took a different approach, obviously, because I saw the two films. Yeah, go ahead, Z.
Let me stop you for a quick second. So Lee, you served as an expert in this case, but you've said that you haven't and perform these procedures. And yet
Which
you
is
serve
why-
as an expert. We should
yeah, well,
explore this.
I think I may have been for causation. It seems to
Right.
me that Juan was also involved in this case, but I can't remember for certain. Juan, if you're on, please say something.
So explain expert for causation, an important concept. Yeah.
So you can be an expert for standard of care, which is everything we've just talked about. But then you can be an expert for causation, which is where you are actually describing where the fault in the standard of care of not performing things up to standard care have caused the patient's disability or death, or what the actual bad outcome is. And I'm sure Bruce can probably explain this, even better from a legal standpoint. But much of the expert work I do is usually on causation. Again, a neurologist taking care of a stroke patient didn't do the appropriate standard of care. Patient has a stroke and a bad outcome, and that's causation. I'm the one speaking on causation.
Correct.
So, Bruce, do you have a better?
Yeah, no, I think that's right. I mean, those are the two battlegrounds in malpractice cases where experts fight are on standard of care. And then once you've established that, the next question is, so what? And that's the causation. Like they breach the standard of care. Well, so what? And then you come in and make that link because that's too difficult for a lay person to understand. And then the other comment I would make here too, going to Ziv's point about the fact that Dr. Jensen hadn't done this procedure. Different states have slightly different rules on who qualifies for an expert. Like in Virginia, we do have a rule that you have to have essentially performed the same procedure within 1 year of the procedure that's at issue in the case. Otherwise, you're not qualified. Some states like Tennessee, you have to be practicing in the same specialty in Tennessee or in an adjacent state. Some states don't have any of those requirements, and the belief is that well, maybe Dr. Jensen doesn't do this stuff, and the other doctor on the other side does, but the jury can consider that in assessing the weight of the evidence. In other words, they'll take into that into consideration when considering Dr. Jensen's opinion, but they can still qualify as an expert. Again, it really can depend somewhat state to state. Virginia, we have a pretty strict rule.
Correct. So let's move on. A nice demonstration of how reasonable minds and colleagues who respect one another can differ in terms of causation and standard of care. Now, this case was the jury found for the plaintiff, and I assisted in performing and making a demonstration, a model that illustrated to them the idea of multiple views demonstrating where something is. So I said, here's a picture. Here's a little bunny or a rabbit in front of a box. Is it in or out of the box? Take another view. It's out of the box. In the box? Yes, different view. And that was an extremely helpful aid to assist the jury in determining that they felt that the physician violated the standard of care. So sometimes things come up that you're unaware of, and it makes for fascinating discussion. So sometimes, Tom, the standard of care issue is not what it seems. This is a brachial nerve injury, and the medial brachial compartment that Tom and I were on opposite sides of the case on. And this story was simple. A brachial approach was done after a failed femoral could not catheterize and embolize the bronchial artery. It was accomplished successfully. Post-procedurally, the patient had significant pain, numbness, and weakness in the extremity. I think it was left. Now, the interventional radiologist was uncertain about what was going on, did not have significant experience in this regard, especially with this complication. So he consulted an orthopedist who said, and that's a quote, "No signs of compartment syndrome. This is a superficial hematoma, conservative management." Days later, the patient developed pseudoaneurysm and ultimately had nerve injury. Dr. Sass was deposed in the matter, and this is what he said. He said that the medial brachial fascial compartment is an area well known to vascular surgeons and should be to interventionalists, but not necessarily to orthopedists. And Tom's point was critical of the standard of care, that this doctor should have explored further getting a second consultant in a vascular surgeon to make sure that they were not missing a median nerve compression. Tom, this is your quote from your opinions and your deposition.
So it's pretty clear that orthopedists work with a completely different conception of compartment syndrome than vascular surgeons and frankly IRs. I think the problem is twofold. One is anybody performing a procedure like a brachial puncture, brachial artery puncture, should have read up on, if he didn't know, the possible complications and the signs and symptoms of a nerve compression. And obviously the radiologist was not comfortable enough in his own mind to know that that's what happened. Unless a vascular surgeon is not available, consulting an orthopedist is really not ideal, to say the least.
All right. And Dr. Sass said that in trial. I responded. I made the following comment. Dr. Sass is asserting that a consultation was appropriate, but he got the wrong specialist to consult. That's what he said. Well, I thought that was nonsense. And I disagreed completely because Dr. should have gotten a different consultation or rejected the consultation of a specialist who took it. And I went on to say to the attorney, well, if I ask you for advice on a patent matter and you give it to me, I assume that you know what you're talking about. So we disagreed fundamentally. I agree with Tom that the interventionalist ideally should have known, but ultimately it is a physician's responsibility, if he or she does not know, to ask a consultant. Tom believed that the standard of care required him not to reject the advice of an orthopedist. I said no, he did what he could. He was not necessarily required to know that an orthopedist who gave an opinion was not qualified to give such. So
may I interrupt for one more?
Yeah, please.
Had he actually, it is inconceivable to me that anybody who holds himself up to be an expert in interventional radiology and would actually undertake to puncture the brachial artery would not know what the potential complications are and whom they should consult. And if he didn't know who to consult, he could have consulted the baker in the laundry to give him advice as much as the orthopedist.
So Tom, having nicely stated it in a strong and extreme fashion, which would be essential in deposition in support of the case, in fact, it's a far grayer area as to what would be acceptable. You know, how far does one's duty need to be in consulting someone and believing that they are reasonably qualified to address something that in other situations they do? You know, in other words, are you supposed to then know that your orthopedist may be a grade B orthopedist and that you didn't quite get someone smart enough, or that if you got a vascular surgeon that you have to get a second one because maybe it wasn't, you know, there's somewhere there's a line here which the court is going to decide as to reasonable.
That's correct.
So that is all correct, except for the fact that if you are a physician, and I made the mistake of having read an awful lot about the definition and of hematoma and various expertise. And it's very clear if you read the writings of orthopedics, they have a totally different concept of the meaning of a hematoma and of its care and diagnosis than do vascular surgeons who deal with this on a regular basis.
Which I agree.
I grant you, by the way, that it is a very gray area. And I did feel very strongly that if an interventional radiologist didn't know who to consult, that's part of the malpractice.
Yes, exactly. Tom's point that the standard of care required that, I did not agree. So we're moving on to the end of our presentation. So let's conclude by telling you things that I've learned.
By the way, who won that case?
Before you go
Yeah,
into
yeah.
summary,
Yes,
if I may. Tom, did you want to speak?
No,
Go ahead, Tom.
I was curious. I forgot who won the case or what.
defense prevailed. My position prevailed.
Ironically, I have served an expert twice in these types of situations, this very injury, for both defense and for plaintiff. It's an interesting area, but I wanted to take a second before you wrap up, Bob, to take a comment from one of our senior colleagues who's on this, who basically has asked, how do you manage potential or have you perceived criticism or retribution from physicians when serving for the plaintiff? And how do you deal with those questions? I think any expert, certainly starting out, is going to have to consider this. Where does this put me in the face of my peers?
Yeah, it is a concern. I have not yet gotten it. I mean, people may think certain things, but in my view, I try to be as objective and as careful as possible in my opinions. But that's ultimately something you can only decide for yourself if you pursue this work.
So one of the things I have found is I started out doing just defense work. And then I did one plaintiff's case. And once I did one plaintiff's case, all of a sudden I had nothing but like plaintiff's lawyers calling me. And I felt like I got abandoned by the defense attorneys until I did a plaintiff's case and we won the case. And then the defense attorney contacted me shortly thereafter and said, do you remember who I am? I'm the guy that you beat in court. I'd like you to do a case for me.
Right.
So Bruce, I'd love to have Bruce talk about this. I would love to do more defense work, but it seems like once you do a plaintiff's case, all of a sudden defense lawyers, you're treated like a pariah. And I think that's really dumb.
Yeah, I don't know. I don't know as a lawyer why we would, it certainly pass around a name like we don't want that person because they testify for plaintiffs. There are things that if names get around that perhaps your client is not, they don't want you for some reason, or it might be that a particular insurance carrier, we're not in the commercial world, but a lot of these, again, these databases are out there. You're absolutely, any deposition you've ever given, everybody has. And, it's possible that there could be that kind of, limited blackballing going on. But I think it's probably more just, word of mouth gets around. Like with your plaintiff's case, people like it, they go after you and they use you a lot. And then, the same thing I could see happening on the defense side. I don't, anyway, it's not been my experience.
Okay,
The
so no
lawyers
secret handshake that I don't know. All right.
I've never experienced criticism or retribution. I think if you're going to do this, you have to be able to work in both, and you have to just steel yourself and say, I believe in the process within the limits of it.
You know what the worst case I ever had was a case that was shown to me without telling me who was involved. And I was shocked at what was done. And after the fact, after I made my opinion clear, I was told that the physician involved was a past president of SIR, and that it would not be considered very honest of me if I had so handily condemned what was done, and then I didn't take the case. And after thinking about it, I actually did take the case, and the opposition marshaled a whole bunch of very prominent IRs who felt compelled to come to the defense. And it was probably the worst experience I've ever had. And I'm not sure I would ever do it again, especially after having sat through the deposition with this person sitting directly across from me and staring at me with every word.
Yeah.
Well, Tom, there you have it. I think that's one of the components of it. So let's wrap up. Just wanted to complete one thing, and these are things I've learned. These are just my pearls from all this work. despite what everybody thinks, informed consent is virtually or never important in medical legal cases. Now, we talk about it a lot. It almost never arises. On a more pragmatic basis, be afraid. Be very afraid about mediastinal biopsies. I have seen more cases than you can possibly imagine about mediastinal biopsy mishaps. I think we approach them way too cavalierly. Third, be ready to treat superior vena cava rupture when you are doing central venous catheter work or central venous reconstruction. It happens more than we know, folks. And unfortunately, the overwhelming bias of the medical literature is to positive results, not negative results or complications. A big problem. Intraarterial PICC lines cause stroke with striking regularity. Central line guide wires, long lengths of guide wires, and Ziv is laughing and nodding, are left in the patient all the time by surgeons and hospitalists. I do not understand this. I have seen 7, 8 cases of lengths of guide wire from 80 to 120 centimeters left in.
It's always the same line, Bob. I thought he'd pass it on his own.
Lung biopsies are to be respected. Bleeding and air embolus can be devastating complications. Emergency department physicians miss a lot of dissections. And finally, know where the nerves live, because if you don't, you will traverse them and cause problems. So finally, the standard of care, remember, is about reasonableness, not excellence. It reminds me of the boards. We're testing for competence, not brilliance. It is defined by experts at trial, not all of whom are really experts. And the criticisms at trial are equally distributed between the things I mentioned: selection, procedural performance, complication recognition, and the response to the complication. Thank you very much for your attention. It's been a lot of fun, folks.
Very well done.
Thank you, guys.
Yes.
Thank you, everybody. I'm very grateful to all of you. Thanks for everybody who's shown up tonight and for your great questions in chat. Have a wonderful evening. Thank you.
Take care.
Thank you.
Bye-bye.
Bye-bye.
Bob and Tom, thanks a bunch, guys. It was great having you.
Thank you, Alan.
Nice to see you, Al. I haven't seen you in years.
Yeah, it's a reunion of Tegmeyer lectures. So it's
All right.
All right. Have a good evening, folks.
Take care,
You
guys.
too.
Bye-bye.
West